Hello everyone, this is Alraies. This is SIF2021. With me is Dr. Megan Coylewright. She is the Vice Chief of Cardiology and Director of Structural Heart at Erlanger Heart and Lung Institute. Megan, thanks for being with us.
Thank you for the invitation.
It's nice to see you again in SIF live. No more virtual experience, which is great. It's safe and educational. Yesterday, you presented a phenomenal talk about ICE guidance structural heart interventions. Please tell us about it.
Well, it is an exciting topic. I think it represents structural heart, and that is we have more choices for our patients now than ever before.
Correct.
So traditionally, a lot of our structural heart procedures, as you know, are done with our patients under general anesthesia with the guidance from transesophageal echo.
Correct.
And we are so reliant on our partners. They've been fantastic to help move the field forward. But as the devices have matured and iterated and become more safe, such as with the Watchman device, the new iteration Flex, we do have the ability to be a little bit creative about device deployment, and that is offering patients choices of being under conscious sedation instead of general anesthesia.
Absolutely.
For some patients, that's really important.
It is, and especially for the hospital length of stay and so forth.
Mm-hmm.
So from your experience, and what is the current rate of use of ICE compared to TEE guidance?
So intracardiac echocardiography to guide structural heart procedures, to be honest, is really in its infancy. And so there's only a few procedures where it's being used with any kind of frequency, and that is left atrial appendage occlusion. And we're just starting to investigate it in some other areas. But even in the area of left atrial appendage occlusion, I would estimate it's probably about 5 to 10% of procedures at the most.
And what is the barrier for not learning ICE?
Well, I think there's a couple aspects. One is for most providers that are using ICE, they're doing both the imaging and the device deployment. So in order to be able to handle both, unless you add another attending in, it can be a little bit challenging. A lot of structural interventionalists have some experience with intracardiac echo through PFO closure or ASD. But typically, we bring in just an 8 French ICE catheter and park it in the right atrium. We're not necessarily going to other views that are needed, as in left atrial appendage occlusion. So for example, in order to clear the left atrial appendage of thrombus prior to putting in a device, which is essential since that procedure is all about preventing stroke,
Correct.
we do have to think about how we're going to be able to see that well with ICE. So one of the best ways to do that is to traverse the tricuspid valve and go up into the pulmonary artery, which lies right next to the left atrial appendage. Beautiful views, and we have a lot of literature to show that that is a very sensitive way to pick up left atrial appendage thrombus. But learning how to put the ICE catheter up there is very different than what we do for PFO. So that's one of the learning curves.
Yeah, I saw that picture you put there. Is it an operator technique that he has to park in the PA, or the catheter is different that are specific for the Watchman?
It's the same old ICE catheter that you use for PFO and ASD. You could also go ahead and do a transeptal puncture and go into the left atrium and clear the left atrial appendage from there. So some operators choose to do that as well, and you get beautiful views that way.
Yeah. In terms of access, is this a problem? You having another 8 French in terms of closure and patient sitting up?
I have to say, for a structural interventionalist, don't we love venous procedures? No, I don't think it's too much of an issue, but obviously we have to have meticulous technique because, again, this is a procedure that's all about prevention, so we don't want to have any bleeding complications even from venous access. But you're right, we typically do use somewhere between an 8 and 10 French venous sheath for the ICE catheter.
So what's your closure technique in these cases?
Well, it does vary depending upon the age of the patient, their weight, their other comorbid conditions. I think we can all agree that for Watchman, which is a 14 French sheath, and ICE 8 to 10, really a manual hold is fine. Yeah. But it depends. If we're doing same-day discharge, which during COVID-19 we did start to do more with Watchman, given the rates of pericardial effusion with Watchman Flex are so exceedingly low, and the potential risk or even emotional impact of having patients spend the night in the hospital without their families is really high.
Yes.
So we were more flexible. So in those cases, I would use one per close for the larger venous access.
And the other one is manual. Awesome, great. So what can we do, including myself, to learn ICE and bring it to our practice?
One of the projects that I'm working on right now is helping to define our standard ICE protocol for imaging. Just like when we learn TTE and TEE, we start at the beginning, we go through the middle, and then to the end.
Yes.
We don't necessarily have that well defined as a community right now, but if we do have that standard ICE exam, you can deploy it during every PFO and ASD so that you're starting to gather the skills needed for more complex interventions, going up into the PA, for example. We wouldn't necessarily be looking in the LA, but you could through a PFO, for example, or ASD. Right. So having a set exam where we have the ability to train others is one step closer. And then I would recommend for those Watchman operators, for example, who have an interest, first establish your skill sets in left atrial appendage closure. Probably about 50 cases under TE with GA. Once you have a good sense of your skill sets there, you can then add ICE on, still GA and TEE, take turns with your echo partner, share the views with them, become comfortable, maybe 10 cases, and then transition with select patients.
Is there a need for a proctor to learn ICE?
I think that would be up to each individual operator and what their experience was with PFO, ASD. Some structural operators, as in my case, have trained in pulmonary vein interventions, so we've used ICE in other situations. So it depends a little bit on the past experience, but I think some of the neat things during COVID-19 is understanding the flexibility of virtual proctoring, of simulation training, and so I think we have to develop some of those tools for ICE guidance so that we can continue to move the field forward and offer choices to our patients.
Well, let's shift gears. I just heard that you are starting a new role on Monday as a woman in cardiology. Can you tell us about it?
I am starting a new role on Monday, which is very exciting. So as you mentioned in the introduction, I will be the Vice Chief of Cardiology and the Director of Structural Heart at the Erlanger Heart and Lung Institute in Chattanooga, Tennessee. And this is a very exciting role for me. First of all, I'm joining a very dynamic, very compassionate team that works at one of the largest public health hospitals in the country. They are really providing essential and exceptional care to a very high need population. And I think all of us can agree the events over the last 1 to 2 years help us reflect what is the impact we're having on the communities that are most in need.
Absolutely.
And for me, as an investigator that's in clinical trials, I want to make sure that we're thinking about how to engage both women and people of color to make sure that our studies are actually measuring outcomes in the populations we serve.
Exactly.
So I think there is a need for us to go to areas, to not all kind of be collecting in the same ivory tower institutions and bring those latest clinical trials to patients that need them. Now, that field is still developing. How can we develop trust with communities which we have traditionally lost over time from the medical standpoint? So I think we all have to work together to understand how we can move that forward. It's something I'm passionate about.
Well, congratulations for your
Thank you.
role, and excited for you, and it's going to be a big role for you, but really for seeing a woman in cardiology serving that role, it's really delightful.
I appreciate the support. Thank you.
Thank you, Megan, for your time. And thanks for all of you watching there. Please watch this video and others on SIF YouTube channel. This is Alraies from SIF 2021. Thank you, Megan.